is a little survey question. If you have an attending that asks you, that says do the following. It's inappropriate to take a spiritual history. I would say one of the three things. A, one, I don't know. I don't know if I'd respond. Or, okay, thanks for advising me. Or three, actually, I've been told it's part of quality care. So let's all vote. Vote for one, I don't know how I'd respond. Okay? No, okay, a couple people don't know how to do that guy. Two, okay, thank you. That's kind of probably what I would do, right? Okay, let's just be honest, right? Three, people get a little risky, like, actually, I've been told that it's part of quality care. Who would say that? There's some people with some. How about another survey question that I was asking in the workshop groups, and I want to ask you guys as well. Raise your hand if you feel that it is ethical and appropriate to take a spiritual history or to have addressed spiritual issues with your patients. Give me a hand raised. From a medical standpoint, not from a Christian standpoint, if we were all atheists in this room, and I'm asking you as an atheist as well, or an agnostic, or whatever, it is appropriate medically to address spiritual issues with your patients.
Define address. Can you define address?
I will define in more detail, but generally at least to ask questions. Yeah, to bring it up, to ask questions, to see where they stand spiritually, what their religious background, things like that. It is appropriate to do that.
Like not advising or asking.
Correct. Correct. So raise your hand if you think it is unethical and not medically appropriate to have a spiritual discussion to see where patients are spiritually. Give me a hand raise for that.
It is or is not?
It is unethical, not. From a medical standpoint, not getting off from a Christian standpoint. Okay, so it looks like we have a couple people that. And let me tell you why this would be important. Just to lay the groundwork of why we're doing this. If we want to, like one of the things that kind of hit me when I was sharing with you yesterday, after I went to a mission trip, coming back in training in the 4 years of med school, is okay, how does this change my patient interaction on a day-to-day basis? If it does, if there's a way for me to incorporate a system, not just the general characteristics of being a Christian doc, which is great, not just the general idea of seeing when a door opens and then walking through, which is also great. The systematic approach to address spiritual issues, that would be kind of great. And that's what we want to focus on this morning. I'll send you these slides. Some of them I took from this really excellent physician out of Duke. His name's Walt Larrymore. Wrote a ton of books, a ton of journal articles on this topic of taking the spiritual history.
Christian?
He's a Christian. So some stats on why people don't. When physicians were asked in one group of family medicine, some said it's because they don't have time, some they don't have experience and training, and some are uncertain what to do about it. So one of the reasons why, even if you believe it's ethical and moral and important, part of quality care, a lot of physicians that you'll see just won't do it for whatever reason, for some of these reasons. And some of you may be in the same shoes as well, even if you think it's important. So our objective for this morning, for this brief session, will be this. We're going to discuss why spiritual history is appropriate, and two, talk about some templates. I don't know if you still have your folders, but we printed them out for you. They're all mnemonics because people know in journals that we learn by just things that rhyme and things that are mnemonics and stuff like that. Some of them are spiritually. There's spirit, faith, hope, and FICA. I don't know where they got FICA from. That's the oddball out here. These are some key questions. Also, I'm going to skip over some slides just for the sake of time. Give you a heads up. The key questions that we're going to be addressing is why is it clinically appropriate? What are the benefits of it? And what are some examples? So the first question is why is it considered? Because it's good that you guys are already with your survey with the background here. We're saying it is appropriate. But if I asked you, because right now the standard of care in medicine is measured by what? Not by what we've done and we've always done. It's measured by evidence-based medicine, right? So I just really like beta blockers. I'm going to use them. It doesn't matter that you really like beta blockers, like they mentioned over here. It's not first line, so you shouldn't be using that first, right? For spiritual histories and spiritual conversation, if I say to you, cite me a journal article that I'm an attending, not in an antagonistic kind of way, but share with me. Where does it talk about that? Is there any medical literature on that, or are you just making that up? So part of this will be to equip you with medical literature. It's kind of like when you have a spiritual conversation, if you ever have like a heated debate, say, I don't know, women in the church or something like that, right? Not to say that we're going to have that right now, just saying. But like you can have somebody who can just gonna invent their own thing and say, I think God wants this and this. Or you'd have someone who's gonna cite scripture and cite church fathers and cite whole tradition, right? So that's what I want you to do for this session, to be able to cite journal articles. If not like by memory, but at least have a reference and say, in the New England Journal, So what we're gonna lay out for the why are these top 5 whys. Just top 5, they're not even all the whys. 1, patient desire. It's important. If we think it's important, that's good. Sometimes we can think, and this applies, I've seen this like medically, and I've seen this also generally spiritually. When we do mission stuff, and we'd have like, the Coptic team that's gonna go out and share Christ with people, sometimes our inclination is that people don't wanna talk about spiritual things. Right? I don't know if you could admit that, but sometimes we're like, no, they're not interested, like people wouldn't wanna talk about that. And we'd be incorrect, and I'll show you why that's the case. Another one could be patient benefit, and we're talking here about objective benefit that's documented by research. An important one will be risk factors, and we're going to go through each one of these in detail, enhancing outcomes and why it's quality of care. So first one, desire. If I asked you survey status, if patients were surveyed in a journal article, the same question that I asked you, when it would be ethical and appropriate to address spiritual matters, what percentage do you think would say, yes, it is appropriate at least some of the times for my doctor to ask about my spiritual life, my spiritual background, my religion? Throw a number out there. Give me a hand raise for under 50.
Wait, what region of the U.S.?
I think it was national. It wasn't like a particular by state, as far as I understand the study. So if that was the case, what do you think? How many patients do you think would be that were part of this study? Under 50? Under 60? Under 70%? Under 80%? I don't know if that's the right way to ask you this question. But basically, what I'm trying to get at is, it's like a weird editing question. So, for under 70, 83%. Does that number kind of baffle you a little?
Yeah, absolutely.
It should, right? Because it's contrary to whatever we would think. We would think if I asked the patient, most of them are going to be averse to it. And one of the things I'll show you, one example, I don't really want to go through it that much, so I'll just mention it real quick. I'll mention it when I get to it. But at least appreciate this number. And this is from a journal from Family Medicine from '04. Not that long ago, and an important, reputable journal. Something you can cite at least mentally. Say, no, actually, attending XYZ. This is the actual cited percentage. 76% want to be asked, depending on the nature of the disease. Makes sense, right? If it's a cancer situation, whatever. But what's kind of more staggering is 24% found it always. I'm coming in for the flu. I want my doctor to ask about my spiritual health. I'm coming in because I have a bronchitis. I think it's appropriate. I think it's always necessary. That to me was kind of surprising as well. Yes?
When they did this poll, did they clarify for the respondents what did they define what spiritual what is spiritual beliefs?
Yes, they did, because they were showing them basically what the spiritual history was, and the idea there was, do you find it appropriate at least some of the time for your doctor to be aware of where you are in terms of religion and spiritual practice? It's kind of a broad criteria, and it was left that way on purpose.
So they left it vague.
Yeah, left it somewhat vague so that it can be inclusive at the same time. So this is what I was going to mention to you real quick. Are you familiar with Wicca, witchcraft, neo-paganism? Of all the people that would have probably a weird thing to believe, who wouldn't want their doctor to be, if you're a mainstream Christian, right? You could be maybe embarrassed about your faith, maybe you don't want your doctor talking to you about your faith. But if you're a Wicca, if you're somebody who's practicing this thing, in this article about them, they would obviously be concerned about disclosure of their faith in a public setting. They could be reluctant, as quoted in the article, it said, to come out of the broom closet. Okay? Their words, not mine. It's kind of messed up, but let's be a little less judgmental here, people. But it would be reasonable, right, for them to not expect this. Or we'd expect them not to want to be open to a spiritual discussion. But what we saw was, sorry, I might have skipped over it. Large percentages, again, we don't have to read the whole slide. 73% agreeing that I have spiritual beliefs that's going to impact my care. So I want my doctor to know about it. 84%. These again are really, really high numbers for probably the most drastic of cases. I'm not saying that you're all going to treat Wicca patients, but I'm saying see in the spectrum of spiritual health and spiritual diagnosis and spiritual beliefs, even something that's kind of odd from the mainstream perspective, even the oddball people, quote unquote, want their spiritual care to be discussed, yes.
Just wondering, do you know how old these patients were, like what the age group was?
I do not, no. It's probably somewhere in the study, but these are a whole bunch of studies, so I didn't go through every detail of it. But if you want, so part of the reason why I'm going to send you these slides is if you want to look into that, the reference is right here, Family Medicine Journal of 06, Hamilton, to see, well, what was the exact age here. Usually, from my experience, like, this is more so mission, less so medical, people in the Wicca demographic tend to be a little bit younger. I don't see a lot of like really, really older people practicing witchcraft. It happens, but I think I grow it at some point. Like, this is kind of weird at this point. But that's just a subjective anecdotal. Cool. So that's again a note on this. This is going to be to the point here of, despite the fact, no matter how much research I show you, that this is quality care and this is important, the research will also show that doctors, no matter how much they appreciate this mentally, or us, no matter how much we appreciate this from a medical standpoint, and then we're pushed by it for a whole weekend spiritually, the data will show the following. Let me show you a couple of things progressing from 94 all the way up to 04. So starting with here, it's supposed to go here, this thing, 94. 80% of doctors surveyed who have never discussed spiritual matters with their patient. It started out being 80% back in 94. Then it grew in 99 to 85%. Then in 02, it's 90. You see the progression here. All the way up to being 91. 91%. Imagine, like the analogy in my head for all this, as a potentially uncomfortable topic, with Maurice and Marianne talking about elderly people, right? Is it comfortable for you to take a sexual history from an elderly patient? Hey, Grandpa, you having sex with men, women, or both? Like, leave me alone, kid. Like, why are you asking me these bizarre questions? First of all, I'm married, so I'm not having sex with anybody. That's what, usually I get from grandparents. So, it's uncomfortable for us as healthcare providers, and for a while that was a deterrent in, as you guys know, right, in giving quality care to the elderly. That's why at some point when we started asking more diligently the sexual history in elderly people, STDs and HIV rates went up in elderly people. Is that because they just started to have HIV and STDs? No, we just started asking the questions. The driving point here is, even if we are not 100% comfortable with something, which we should be at least, doesn't change the data. Doesn't change the fact, I'm not a big marijuana smoker. It's not really my thing. But I'm still going to ask patients if they smoke marijuana, right? And I had one patient once who was very, very discreet. I said, hey man, are you using any drugs? He's like, Doc, I'm high right now, son. Thank you. Well, Doc, you're high right now, comma, son. So, all right. But you got to ask the question, right? So again, the general numbers were even higher than the numbers for the neo-pagan exclusive, one demographic group here. 87% wanting their physician to understand how their belief system influences how they deal with being sick, or to understand them better as a person, or to understand how they're making medical decisions. Again, looking at the gambit of spiritual beliefs in this country, would you want to operate on a Jehovah's Witness if you're not knowing he's a Jehovah's Witness? You wouldn't want to do that. Would you want to give long-term diabetes care to a Muslim not knowing about Ramadan? Would you want to care for a Coptic person not knowing about the Great Fast and them not eating for so amount of time on Fridays or whatever the case may be? Right? No-brainers, essential, we have to know about. Hopefully beating that to death with some citations. Other reasons why patients are saying that: for hope, advice, change of medical treatment. Again, the reference there from an 04 mark. And this is all under the context of patient desire. Does it beat it home so far that the patients want this? So it's one thing, this is important for us, but the other thing is, contrary to what we may think, it is documented, patients want this. Patients believe it's important because they want to be understood. This changes their decision making. It changes how they view illness and coping mechanisms. Any questions on patient desire? We all agree patients want this based on medical literature. Cool. Then we move on to what's potentially maybe even more important. Because even if patients don't want this, if you're going to identify risk factors, that will probably be even a bigger driving force because for a lot of people, religion and spiritual stuff is a source of comfort. For some of them, it's a source of turmoil. For some people, it's awful. Let me give you an example. And again, just jumping around a little bit, I want to get to this one slide. With each one of these, I personally, and I didn't have a gigantic long medical career, just med school days. I had a patient named Denise, we'll call her that, it's not her real name, who was doing terribly even though her actual medical status was not that bad. Her actual disease status was okay, like relatively speaking. Her husband was in renal failure and he's, on his way out. But she was doing terribly because, and when I asked her more about what's going on, firmly believed that God was punishing her. And no matter what she did, that influenced how she took medication, influenced her doctor's visits, influenced where she went to the hospital, because God doesn't want me to be well. Tell me more about this God. Let's talk more. Halfway through her crying and halfway through us having this conversation, found that she actually had a Christian background, was able to just reorient her thinking that God is not punishing her. That your God, the God you believe in, Christian lady, doesn't operate that way. That changed her medical outcome significantly. Because she had a wrong idea about God. Imagine the rest of these, okay? If you're a patient, like I had someone once tell me, hey man, do you know what it's like to wake up every day when if you believe that people don't like you, it sucks. If you believe that your parents hate you, it sucks. If you believe that your friends turn against you, it stinks. If you believe the almighty, most powerful being in the universe is against you, that's overwhelming. I agree. And if they believe that, we have to try to counteract that. These numbers here, I want you to just know something. You know there's the difference between mortality and morbidity, right? Morbidity, bad. Mortality, bad. In this study, in 01, in Internal Medicine Archives, 19 to 28% of them experienced higher mortality.
That's a bad one, right?
That's the bad one. Okay? I mean, if it was 19, if it was 19 to 28% of them experience high morbidity, that still sucks. That's terrible. We should prevent that. We should avoid that if we can. Because again, I think it shows on the next slide. But yeah, it was independent of health, mental health, social support, whatever their situation was, all the confounding factors apart. These patients who had significant spiritual barriers, believing God hates them, punishes them, whatever, are dying more often. That's not okay for us as healthcare providers because we are not comfortable with spiritual conversation. And I'll be honest with you now, okay? I didn't get into this as much with why doctors aren't as comfortable, but we got to be honest that we can be forthright. And attending with an American culture could be uncomfortable for different reasons. I'm too scientific, I'm not going to be spiritual. A Coptic attending, maybe that was taught in Egypt, that you open your mouth and we rock you. And then coming here and practicing as like the foreigner who's just like trying to stick to, hey, don't single me out. I'm just trying to get my job straight. I don't know if you have that kind of experience, but I've had a number of Coptic attendings. My church, New York, New Jersey, who tell me, Habibi, ewa, never talk about spiritual with the patient. Never. And I understand that when I was going to Egypt. Like when I was going to Egypt on a medical campaign, I went to Mena and all these kind of places that we did outreach with munaqabin and stuff like that. And my parents said, if you open your mouth, if they don't kill you over there, we're going to kill you over here. I said, okay, because they know I'm crazy. Fine. I understand that. I'm Egypt. Fine. Egypt. Here in America, you will not lose your job for discussing spiritual things. Again, we're going to discuss how you do that. But just so, you can definitely answer your Coptic attending. If you're not going to answer your other one with respectfully and dutifully, say, I've just seen some articles to the contrary. we have to also do an attempt to educate our older Coptic physicians who think that they will be risking their own neck or their own job. And again, I'm not telling you anything contrary to the law of the land. I'm telling you this is the law of the land. Make sense? Not to rag on Coptic physicians, but just to tell you the reality of where we are. So that significant increase in mortality. Sorry, it just seems to be freezing. Okay, good. May enhance healthcare. This is important too. If you want to, it's good to prevent the bad stuff. It's good to prevent the mortality and the morbidity. But it would be nice if you can also do something positive. Right? So, this is a study out of Georgetown where they basically reviewed they compiled a whole bunch of data. And this is something you've probably been familiar to. After they empirically reviewed the data between religious factors, and there were a lot of loose religious factors too, like in terms of religious involvement. Yeah, it was these small, sort of subjective criteria. Frequency of religious attendance, private involvement, and your own personal belief and stuff like that. They kind of saw people who had these things more in their life. And you can intuitively think this. You have a stronger support system, you have more people around you that are going to encourage you, that kind of thing. And that generally will support your outcome, right? And they saw there that it was helpful in terms of recovery, coping. I won't belabor this because I think it's something that you can kind of intuitively think. But imagine if this idea came in a pill. If we had a pill that you're going to market that's going to A, identify risk factors in patients, B, enhance their outcome, help them cope, help them recover, improve, how they deal with physical and mental illness, it will probably do pretty well. Somewhere up there of more than Viagra and stuff. It's going to do its thing. Okay. Any questions on that part of enhancing healthcare outcomes? So we believe so far that that the patients want it, that it identifies risk factors, and that it's going to actually improve where we are. Part of quality care, and this is probably one of the important ones as well for me because it all culminates. We weren't the only ones to study this. And by the way, so this is not stuff that's groundbreaking medical literature 2013, right? They just came up with this, oh my God, patients have spiritual lives. This has been going on for a while, and it's nice to see that professional organizations, the ones that set standards of quality care, from the APA down to the AMA, and you see these are all numbers in the 80s and 90s, because they established this a long time ago, that spiritual care is a part of quality care. These are all that have made it blanket statements, just standardized it. More of the same, if it comes up. Yes. So these are professional organizations, like I said, that are both have said that it was part of quality care and are also calling for it to be a greater element of quality care. Most probably importantly in '96, you guys are familiar with JACO, the Joint Commission? So these guys set standards all across the board. Hospital care, outpatient care, inpatient care. These guys set the standard for a lot of things that we abide by. They're kind of like the Holy Synod, in a sense, to make it a spiritual analogy for you. And here's what they said. They said they should, at a minimum, determine the patient's denomination and belief, what the spiritual practices are important to them, and the information would assist them in how they care for them. Again, not beating that to death, but does that make sense as well now that it's by professional organizations, they've established it's part of quality of care. Cool? Now we get into the practical element of it. Yes?
Before we move on. So I think that part of, the hindrance of involving spirituality in care is that there's this idea that anyone that does ask about it is trying to convert someone.
Yes.
There's this fear of over-proselytization.
Absolutely.
And how do we as Christians not come off like that? If I'm curious to know about someone's spirituality, I'm not trying to convert them.
Right.
I want to help them.
Absolutely.
So how do we kind of alleviate that fear that most systems might have, but also still fulfilling
Definitely.
our job as providing good care?
So great question. So a couple different ways. And part of it is on the later slide, but I'll just tell you now anyway. When you're approaching it with sensitivity, with permission with professionalism, the same way that, for example, the sexual history just seems to be the easiest comparison just because it's the most awkward for most physicians, again, according to the medical literature. If I have a homosexual patient, if I'm going to be addressing them, not to try to change them, but to know more about their lifestyle, because I want to know if there's risky behavior, if there's anything I could do to minimize that risky behavior, or to have the increases better outcome. Me not imposing my view on his sexuality, or in this case, me not imposing my view spiritually. None of this that I'm going to tell you, because this is another thing, just like you're saying, whenever we think about spiritual stuff, we think it's going to be like, whether in the context, to be honest with you, of medicine, or even outside of medicine, what I've seen now in 2 years, in the past 2 years of mission, is whenever we're talking about faith and spiritual stuff, we think what we're supposed to do is like, hey, do you know about Jesus? And people don't want to hear about that outside. They don't want to hear about that in the operating room. They don't want to hear about that in the clinic. Nobody wants that approach, as much as I've seen. But people do want, and they appreciate, and you don't come off as proselytizing, which is, nobody wants to proselytize. Sounds like prostitution. So, I know it just sounds like a proselytization. It's a terrible word. You don't want to force your beliefs on anybody, right? But you do want to understand where the patient is, so that you can know, as one person said, to help them in their journey, and for us spiritually as Christian healers, to see how Christ can join them in their journey, where they are. So none of this is about me saying things to the patient. These are all going to be questions. If you notice in the templates that I gave you in the folders, they're all questions. They're not, top 4 objectives that I'm going to tell you in this lecture. Patient, sit down, let me tell you about spiritual life. So that's sometimes the difference. Is even the exact approach of question asking versus lecturing the patient is by nature not imposing. It's by nature not me telling you stuff. It's me asking you where you are. Does that make sense so far? Yes?
Also, to add to that, sexual history is part of the social history, and as another part of the social history is to ask about the support system. So for a lot of people, the church is the support system. So I think it's pretty standard to ask about that.
Yeah. So it's definitely standard, and for us it's important not to feel weird, not to feel like, even when you're asking about the support system, it's not that we're forcing them to have the same support system as we do. We just want to know where they are and want to be able to encourage them where they are. So some tools. And again, the purpose here, as documented by this article, is to understand the background of the patient, what role the spirituality plays in them, and how their beliefs influence their decision making. What happens too as well with this is when you have a system to at least, this is of course an introductory kind of thing. If we can introduce spiritual history, and if you from now on the student level, if you can learn to incorporate 1 or 2 of these questions or 1 or 2 of these tools into your general routine, then it becomes much more easy for you down the line. Like Dr. George yesterday shared with us an experience in which he was able to really take off at one point in his medical career, right? In terms of medical missions. It would be great though, if for the future, for you guys, if the seed of medical missions locally and abroad is planted, imagine from your first year, from undergrad, of wherever, and you kind of already have that system going, the same way that the idea of practice makes it second nature for you. You know how you take a physical, how you take a history, otherwise. Then the questions become second nature to you. So if you're able to internalize some of these questions, what happens is a gate becomes open with patients in which they know that they can discuss spiritual things with you. For me, in my experience, at least in 3rd and 4th year, I can't tell you how many patients I got to pray with, pray for, even if it's not that conversation, by asking them where they are, see how we can have a convo about that, how we can move from, like I told you about that patient Denise, or the other patient who, not the one that was high right now, but someone who was really struggling with different drug abuse. It was cocaine for him at the time. We were able to discuss that, the spiritual element behind that, why he was turning to cocaine because of his circumstances, and so on. Point what I'm making here, the editorial point, is if you're able to do this, at least you open the door of spiritual conversation. And from that, when the patient is comfortable with you, they're able to kind of go further, and you can go further, because they know, because of the other things now that we talked about before, the characteristic of a spiritual person, you know, with Christian presence, all that kind of stuff, it goes further. So one tool that you have in your folder as well, it's out of the Archives of Family Medicine, 96. It's spirit. Spiritual is the mnemonic. One question is, you know, about the spiritual belief system. Do you have one? Do you think it's important to you? P is personal. What is your religious or spirituality? What does it mean to you? I, how you integrate it? How do you participate? What support system do you have? That kind of thing. Sorry, it's hard to see.
Yeah, can you stand on the other side of the laptop?
Yeah, that makes sense. Or I could just move. Probably done this all along. Or, oh, you can't see that.
No, oh yeah.
You think I just looks at previous slide quickly?
Yes?
Yeah, I wanted to see that third.
Is one in the way of the
Okay.
Does this work?
Yep.
Cool.
Mena, just like one more thing.
One more second.
I'm gonna just go home.
Over there, Mena.
Yeah. Put me in timeout. Move the thing over?
Yeah, you got room.
There we go.
You're playing me out hard. Okay. So this is probably the most important bit of the presentation, the actual tool. Because there are a lot of tools, and what I'm gonna share with you is not an exhaustive list. Just a couple of like top 3, 4, 5. Except for FICA. I don't really like FICA, but whatever.
I was saying, it's like, all the words are like no, faith,
Yeah.
hope, spirit.
I was waiting for love. Somebody bring out the love one, and then they brought FICA. Like, so that's so spirit. And if you misplace this paper or in your folder, maybe we have some extra copies or something. We'll try to get you. But hopefully you didn't lose it because it's cool. We wanted to actually laminate it for you. You know, oh, that's really cute, but maybe you can at least have the physical paper. Cool, so we got this one here. Spirit, S-P-I. I mean, you know how to spell spirit, but you know what it's short for. Ritualized implications, terminal events. And this is actually one of the longer ones, so you may or may not remember this one. Then there's this one, FICA. So faith, impact, community assistance. Is faith/God important to you? What impact does it have on your life? How important is your faith community to you? How can I assist you? Again, if you notice the questions here, none of them is, can I tell you about faith? Right? Yeah, can I tell you why faith is important? These are maybe like Sunday school questions, like if you like, you know, when you were like the annoyed kid of like, is this question rhetorical? Is it not? Do I answer? Love. That's Jesus.
Maybe I missed this. So that's not for a second.
No problem.
But when you're saying, how can I assist you? If they do have a faith, if they prescribe to whatever faith they prescribe to, and they tell you about it, and tell you how they're active in it or whatever, and you ask, how can I assist you? And I know you say, we're not trying to force our beliefs, but as a medical practitioner, do we kind of say like, you know, this person's faith is clearly helping them in their lives.
Right.
And I know I don't believe in that faith, but I realize the value of that faith they do have. And since I'm not trying to convert them, per se, in the medical office, is it my job then to take that job of the medical provider and just kind of support that good thing I see, the good effect at least?
Right. So, of course, it's going to vary based if you're someone that's going to give like long-term care, like in the primary care setting, versus like any other setting. But I'll give you an example of primary care. How I've seen like in one clinic that I worked in New York, treated a lot of Muslims and Hindus and so on. At least in the prevalent, like in the beginning, you have to encourage the good thing. Encourage, yes, this faith is important for you, great. And let's keep that as like a noted thing, literally noted in my chart, you know, of like where they stand faith-wise, and encouraging them in it. And it at least allows a dialogue about faith to be part of our interaction as a doctor-patient relationship. And I saw that that was really valuable, right? And throughout the course of the treatment, there becomes different times for conversation within the scope of that. Now that my doctor respects my faith, my doctor encourages my faith, if I have other things to talk about within the realm of my faith, it becomes like, okay, and there are a lot of Muslim patients, well, not a lot, but I know of some that we've dealt with, that were okay with me praying for them. I'm not going to pray, you know, to Allah, I'm not going to pray in the name of Muhammad, I'm going to pray for Jesus, you know, to Jesus. And they were cool with that, because they know that I'm their provider, I respect their faith, but they see that spirituality is important to me, and it's important to them, and we kind of met in that halfway point. That was the bridge for us, and allowed us to build on it. So it's important to kind of find meeting ground, you don't want to burn any bridges with any patient. If faith is important to them on any level, you can always use that to encourage them and point them to be encouraged in their faith, and also from our standpoint as Christians, to kind of be examples and to kind of show them why Christ is important to us as well. Sometimes it's not verbal in the onset. Sometimes it comes with time.
Do you wait for them to ask typically? Like, do you kind of wait for them to provoke the conversation? Like,
About Christianity specific?
yeah, like the thing, the dialogues will get you down that path where you'd be talking about Christ. Is that something you kind of like longitudinally kind of wait for that, wait at the right moment where they're asking, like maybe one day they're like, I believe this, but what do you believe, kind of thing?
Right.
And then like, is that what you kind of wait for? Is like your kind of cue to?
Absolutely. And in a lot of sense, that moment only comes when they see that the door is kind of open and dialogue is kind of begun with you. And then kind of like the research shows, like maybe in the non-acute setting, all that happens is that you establish this relationship spiritually. And from the many times that I've seen, patient then, even if they're not in a bad acute medical situation, now they have a loved one in the ICU or whatever, there's that saying of like, there are no atheists in the ICU, right? There's no atheist in the foxhole in war, and there's no atheist in the ICU. At some point there, you just call it to God. So I'd agree with you. I say, yes, that is the case of like, as you build the relationship, then becomes specific situations of open doors. And the key for us, sometimes we're just looking for the open doors. Sometimes we're just hoping to be Christian physicians, and then hoping at some point that like they're just going to ask us, hey, why are you so Christian? Which can happen. But at least if you lay a foundation of spirituality is important. It's important to you, it's important to me. And there's a whole like host of other ways where you can show the patient that it's important to you. Like one of the things that we did when I was in school, there's this thing called the saline solution. It's like a nerdy spin-off. I'll show you a slide about it. So like, when Christ calls us to be salt and light, right? You can be salt, or you can be a hypotonic saline solution, or you can be hypertonic. In both cases, hyponatremia is very damaging, and hypernatremia is very damaging as well. If you're not the appropriate amount of salt in the life of the patient, you are doing them a disservice, whether too much or too little.
Love that analogy.
It is kind of cool, all right? Because it makes a lot of sense for us medically. So in order for us to do that well, it's again, like how do you learn how to manage hyponatremia? I'm just going to wing it. What's the worst that can happen? What are they going to herniate or something? Not a big deal. Like, it's a big deal, right? Medically it's a big deal. Spiritually it's a big deal, and that's why it takes a little bit more even than this discussion. This Saline Solution small group series that we went through in school was a 10-week thing that we went through every single week together as a fellowship. And that's, by the way, as a side note as well. For us as a student chapter for CMANA, this would be one of our goals long term. How do we learn this more fully beyond just one session? Make sense? Yes? 5 minutes. So FICA. Faith. Faith, apply, involve, treatment, help. Make sense as another model? We're going to run through this a little bit quickly, though, the models here. This is hope. Source of hope. H, organized religion, personal practices, effects. Cool? So that was hope, faith, FICA, spiritual. We may not get them all right now, but at least, and again, every single one of these, I don't know if you see the reference, but none of these things are questions that are like invented. They're all from journal articles as examples for healthcare providers how to ask spiritual questions. And there's another one, this was not documented, that's why I put them all in the end. Just one doctor thought this was kind of easy for him. So just the God questions. Is God, spirituality, religion important to you? And then others, and I. That's essentially where these are categorized in. God, spiritual, religion, others, I. Make sense? Some quick how-tos and cautions, like we were kind of beginning to mention here with your question. So you got to always approach it with permission, with sensitivity, and with respect. And when patients do that, let's be honest, right? Do you think the big complaint of patients right now is like, you know, my doctor is always like, all my business. Always want to help me so much. Like, none of your business, doc. Is that like the big issue with patients right now? The big issue is like, my doctor doesn't care about me at all. I come in and he's like, next. Like it's a grocery list. Overwhelmingly, if you have the idea of approaching them with permission, respect, sensitivity, like, maybe this might mean something for me in a couple of years of medical practice, but I've seen physicians who practice for 20, 30 years and say they have never had a patient say no to them when they ask them, can I pray for you? Why? It's not because they're asking every single patient, but they're batting at 1,000 because they're discerning, they're being discreet, and they know that they built a relationship. And for the most part, patients, especially as we saw, in situations that are dire, they want anybody to pray for them. I need something. You're my doctor and you care about me spiritually? Wow. For a lot of patients, this is a big plus. It's not like an invasive plus. And even, I'll share with you one story that I heard from a friend of mine. He was saying there's one dude basically who was like crazy, like antagonistic atheist / agnostic person who was just like aggressive about everything in the office. Then he had to have surgery. Before he had surgery, the doctor was the one who was, going to see him before he was going to go into the operating room. And he said, listen, for me it's kind of customary to offer to my patients before surgery, because I know it can be very traumatic and stuff like that, to pray for them. Would you want me to do that for you? And the guy was like, of course. He like grabbed his hand. He was like a massive, like gorilla kind of dude. and he thought, the doctor, when he was like grabbing his hand, he thought he was gonna like crush him or something. He was like, oh, maybe I shouldn't ask this guy. The guy was like, doc, please, and he started crying. And he was like, yeah, sure, I'd love to, And we'd be surprised, like, how patients will respond when we offer something like that. So this is the spiritual note as well. And Dr. George, I'm glad, kind of hammered this in yesterday. Take off your shoes. Not physically, because that's hygiene and situation. But for us as medical professionals, the whole scope of all this conversation, if we approach the clinic, we approach the hospital, we approach the patient as an altar in which you will now perform your priestly duty. Like if you had the time and it wouldn't be weird, we could do a matanya before going into every exam room. And priests, as you guys know, the ones who get this would do that. Right? Father Bishop Camel in Egypt, before seeing the sick patient, what would he do? He would do a matanya. Because why? He's going into an altar where he's going to meet Christ. He's going to meet Christ in the sick person. The sick person will meet Christ in him. This exchange, this idea of taking off your shoes like Moses in Exodus, because you're walking into an altar, like George taught us with the mercy seat, is a game-changing concept for us of how we approach this whole idea. And it allows us, like one doctor that I used to work with would actually